Thanks everyone for coming to the Jones seminar today, where we'll be hearing from Dr. Petr Brůža, who is an assistant professor of engineering here at the Thayer School and also holds adjunct appointments at the University of Wisconsin-Madison and the Dartmouth Cancer Center. So Petr received his PhD from the Czech Technical University in 2014, completed postdoctoral training at Czech Academy of Sciences, and has done research internships at Brown and Stanford before coming to Dartmouth, where he spent some time as a research scientist. He joined the faculty at Thayer in 2018 after having research scientist positions and a research associate position. In addition to his academic appointments, Petr is very involved in the medical device startup community. He's a lead scientist at Dose Optics LLC, which is a Thayer School spin-out company dedicated to monitoring radiation therapy, and has more recently co-founded additional medtech companies. So today he's going to talk to us about his research, specifically the role of new optical technologies, many of which he's developed, to improve outcomes for cancer patients. So let's welcome Petr and forward to his talk. Thank you.
Thanks, Scott. Thanks again, and everybody for coming. It's a great pleasure and actually honor to join you on the Jones seminar. I think this is a perfect forum for actually just broadening our horizons, but also just to learn about the community, what we do, and we've seen many great speakers across the US and everywhere. So again, it's a great honor to stand here aside of them. So it's just my conflict of interest. As Scott said, I'm involved in companies, but I'm not gonna use any bias to that. So thanks for the introduction. So I came actually from a field, just was thinking about introducing myself a little bit. So from a field of more of a theoretical or basic science, which involved high energy lasers and X-ray lasers to study photophysics and biological particles like virus particles, performing perhaps X-ray X-ray holography, or we're also building our beam lines. We are involved in a lot of experiments at these experimental beam lines at SLAC, Stanford Linear Accelerator, and elsewhere. And what kind of actually steered me to Dartmouth was kind of this not a lack of the immediate kind of application, and kind of I kind of lacked this the vision of that I can actually in my lifetime somehow steer a little bit and improve the outcomes for patients. So, but at the time this was absolutely amazing. Like when you walk into these beam lines, it's like everything is top notch and high tech. One-of-a-kind experiments, and you can kind of see the smug face up there. So it was terrific field, but again, kind of steered me away, even though it was such a perfect place to be. And I think that's what kind of connect us to biomedical engineers, to kind of this need to really see the improvement kind of more immediately, and really even perhaps a little smaller scale, but be able to tinker with devices and develop some techniques on our own and see their applications in the field. So I was extremely lucky to get the position here. Extremely lucky because Brian didn't delete the second email I sent around just to apply. Also, thanks to my wife, Shah, I kind of applied and got the postdoctoral position at the then newly built laboratory of our optics in medicine lab. We are at the DHMC at the Williamson building, and with a very close vicinity actually to radiation oncology. And there was always, or since I joined, there was a very nice synergy between these two centers. And so I came to US, and Brian picked me up at the entrance, and we walked through the facility, then went to the Radong. And the first thing you see is 1985 linear accelerator, really like beaten up, down for maintenance. And one could think like, oh my God, like I have to play with this relic now or something, right? No. This is actually this is like blessing. And that was really thanks to another guru, aside of Brian Polk. Obviously, everybody knows Brian Polk. Another guru in the field of medical physics, now director of medical physics at Thayer, medical physics program at Thayer, David Gladstone, who actually enabled this 24/7 access to a clinical grade LINAC, where we could kind of iteratively develop all kinds of crazy techniques and devices, test them in the field, basically, really just down in the basement. And this is super unique. Just the combination of the closeness of these two facilities and the willingness of the teams there to actually share the access to postdocs and PhD students. That's really unique, actually. There's not that many places in the bigger schools and everything. There may be obstacles to actually establish this. And I think this is very unique at Dartmouth, and that's what makes this place so great. So yeah, again, super happy to be, and Brian was my mentor since the day one, and he still is. So obviously, the Dartmouth has got top-notch radiation therapy devices, obviously, so we can definitely translate even further. But it was really the access to these older LINACs that actually kicked off a lot of development and pushed us really to be the front runners in medical physics and associated optical guidance and optical devices, optical device development. So now, finally, let's go to the applications actually that we work with, and I think it can be divided into two categories. Obviously, radiotherapy, as I began with, but also surgical navigation. Obviously, you also know about the great research by Professors Paulson, Holter, and Scott Davis, and Kim Semko. Everyone's amazing amalgam of researchers. And specifically, or more specifically, we kind of work in these four fields, which I'll try to describe, and perhaps there will be some kind of, I'll try to induce a little bit of inspiration, maybe even if you're out of the field, but certain approaches could be translatable to yours. So we aim at visualizing those in radiotherapy patients, and also kind of similar platform allows us to push the field of the new or novel radiotherapies. And the same kind of platform, just a little modified, also is able to image hypoxic tissue, not just for surgical guidance, but also to inform some radiotherapy. There is a little overlap. And some little bit more crazy ideas about implementing some novel sensors for depth sensing in tissue. So let me just start with the most perhaps mature field that we developed, and which is imaging dose in patients. And just to know the need, or why do we need to image dose in patients as it's being delivered, just wanted to give a little bit of a rundown or a primer on radiotherapy. So radiotherapy is actually one of the key 3 or 4 key methods of cancer management, obviously. It's perhaps about half of patients will undergo radiotherapy in one way or another, and combined or alone. And it contributes really towards a lot of curative treatments. These numbers will definitely change depending on the type of cancer and its stage. But so don't put me on that. But I just wanted to point that it's very important part of cancer therapy, and it will be for next years onward. And it works really using, as hopefully know, definitely know, using ionizing radiation, high energy ionizing radiation in the form of electrons, X-rays, and protons. And what it does, or the mechanism to cure cancer is through inducing DNA breaks, right? Single strand breaks, double strand breaks, other types of damage, mainly to the DNA, and realizing the fact that the tumor cells are less capable of repairing this damage. It is, it's kind of, you can kind of see that on the curve, on the dose response curve on the top, where the healthy cells, thanks to their entire environment, they're able to repair more of these strands. And there is a certain therapeutic window of doses that the clinicians use and prescribe to a patient so that we minimize the effect of the radiation on a healthy tissue. Now, with the prescription, it follows with the medical imaging where the tumor is delineated. There is a computer-aided treatment planning that takes these outlines of the tumor and sensitive structures and iteratively optimizes the angles, dose, and the shape of the beams, number of angles, and so on, in order to optimize the treatment so that the dose is homogeneous and maximal in the tumor and minimal everywhere else. And obviously, the planning is followed by delivery. It takes a couple of weeks for a reason. And it's delivered by these machines, linear accelerators for the X-ray and electrons, and bigger facilities that involve like beamlines with cyclotrons at the end to deliver proton therapy. This is very just 101, very, very simple. The problem or the field where we want to help here is actually in the remaining healthy cells that actually do get still irradiated. So we have to make sure, because the radiation still damages the tissue and it does cause chromosomal aberrations that can lead to secondary cancers or other types of kind of unwanted effects on a patient's late or early or late effects. And we really try to minimize these effects. And that's where the Cherenkov imaging can help. Because if you look at how the treatments are delivered, this is typical console. You see some therapy parameters. You see setup cone beam CT, where we know where the patient is, but only at the setup, in the beginning of the treatment, before the therapist and everybody come out of the room. So the patient is set up on a table. There may be other methods how to ensure that the patient is in the right position. Of course, the machine is extremely accurate. All of this is delivered with units of percent accuracy, 3% accuracy dose, sub-millimeter precisions, and accuracies with the positioning and everything. But you don't see basically any kind of direct feedback. This is more like an indirect feedback for what's going on in on the treatment table. And as we will learn later, we did believe that this is not enough, and it may not be actually enough because of other issues of the patient compliance. Patient can move. The setup may not be enough. We have a lot of soft tissue, motion induced. There are other cases that are more kind of human related and workflow related that may not be captured by any of these modalities. And there's always a niche that something's going to go wrong, right? And we really try to minimize the negative impacts of this therapy on already a bad case of cancer. So we kind of, this is a little bit of an exaggeration, but at some point, you're kind of thinking that the analogy could be like having a surgeon being blindly just cutting some tumor out, right? It is an exaggeration, but there is a little truth to it. So how could we visualize the dose? We cannot see ionizing radiation really, or these at least high energies, because our eyes are really working only in a visible spectral range. But we can always image the visual or visible signatures of dose delivery in material. One of these signatures, or one of these kind of effects that result from interaction of the ionizing radiation with, let's say, water or tissue, is Cherenkov radiation, which is basically a broadband light emitted in a form of sort of an electromagnetic wake that's trailing behind these secondary electrons. As you have the primary beams hitting the tissue, they generate usually usually for electrons, X-rays, generate secondary electrons. And as they deliver the dose, these are the agents basically the agents that do the therapeutic effect. As they deliver their dose and ionize the tissue, they're energetic enough to induce the Cherenkov effect. The problem is this mechanism is super weak. It basically, you can only see that in high dose environments such as in nuclear reactors. And it's extremely weak in radiotherapy. We cannot see that basically. But there must be a way to detect that. And we were crazy enough, thanks again, Brian, who kind of started this, crazy enough to try to detect it in a also optically hostile environment. We have to have the patient in a room with room lights set up, because of the patient's safety. And what we're up against while detecting this light emitted from these beams with the doses and the currents or the dose rates used in conventional radiotherapy, with an ideal detector positioned like a couple of meters away, we would get units or tens of photons per millimeter squared emitted from the patient. That detect, we just get like 1 photon or something. On top of about 1,000, maybe 10,000 photons of the room light. If you're gonna convert the numbers, it's gonna be like that. Another thing is the Cherenkov is blue weighted, but the tissue preferentially absorbs the wavelength or the photons of shorter wavelengths. So what we're left with is really this red kind of spectrum of photons emitted from the body. So this is unsolvable. Even if it's a proper detector, if you remember or came across photon shot noise, basically it's impossible to detect single photons out of 1,000 photon background, or even more. Luckily, we could utilize, and we have utilized the pulsed nature of these beams. Most of these linear accelerators are pulsed with a structure where these pulses are on a microsecond timescales, spaced or with their period being milliseconds. So right there, you have 3 orders of magnitude enhancement of the contrast or the dynamic range. If we are able to gate our sensor to detect these photons only during these pulses. But then we're still left with the problem of very low just photon counts. Normal sensors that you have in phones or the CMOS sensors, their readout noise is typically much higher, and it can only record, let's say, tens of photons at a time for us to be able to discern this signal on top of the background of these sensors. So we had to bring in a device that would amplify this very low number of the flux of photons to something that will exceed the read noise of a sensor that we could utilize for just a digital readout. And the thing was, obviously, like one of the first thing we can think about is image intensifier, which you probably know from the military applications for night vision. The construction is perhaps the same. There are some differences because in addition to these applications, which only change the gain of the sense of the intensifiers to prevent blooming and blinding the operator, we need to gate this photocathode. So it's even more difficult. We cannot really just put these military-grade intensifiers to this application. We need to come up with something more scientific or customized. And it was difficult to get this going. But so now we have concept that will work, and it still works. We have this intensifier, and we have a CMOS sensor. One last interesting thing, and that's probably many of us who are in the medical fields and trying to develop devices, is that it's impossible to interface with existing medical devices because of the regulatory burden that the company, whatever you would want to plug into, they would really not allow you to plug into their machine. And that basically, you need to keep that in mind early on while developing these technologies, that you won't be able to just go to let's say, Varian and ask them, hey, can I plug into your machine? They'll say, absolutely no, like, there's no way. So we had to develop a third component to this camera, which was this kind of a detector that will allow us to synchronize this gating to these pulses of the radiation. And that was this scintillator detector, basically two pieces of crystal that convert the stray radiation that's present in the room every time this beam goes on. So we detect the stray radiation and plug it into the gate sequencer, and now we can synchronize the photocathode during the in sync with these pulses. Another problem is now we still have the background. We need to subtract the background, so we need to start doing some kind of sequencing into the CMOS sensor or the attached FPGA, the field programmable array. To perform like background plus Cherenkov images. Right now we can do sequentially. There may be sensors that can do it per pulse, but it has to be done that we have to measure both the signal plus anything of all the background and the background itself to be able to subtract that and really recover just the beam on top of some kind of grayscale background. Over the years, this is actually how it looks like. This was the later designs of the camera. We've had, in addition to all these components, there is a coupling lens. The photons don't just shoot out right from the face here, because the photocathode. I'll also think about it. I'll talk about this component a little bit later. But these photons would be emitted into all directions, so we need to re-image whatever is coming out of this phosphor onto the sensor. That could be done by gluing it, which would induce problems with basically machining and assembly, or we can involve a coupling lens. But again, this is a very expensive piece, for example, for a short distance re-imaging or image relay, how's it called. But anyway, so we built this and it worked pretty good. Over the years, actually, it took a lot of years. One last piece to that is really the real-time image analysis that has to be happening. Plus, there is a lot of denoising algorithms and additional motion removal algorithms that also have to happen perfectly. I just fast forward. I just wanted to show you because I think for the sake of time, this is what we actually seeing in a true field. This was a retrospective study that we've kicked off here at Dartmouth, and this patient, he was set up perfectly, arms up, and many times during the course of therapy, he would just move the arms straight into the beam, right? So normally, if this would be presented to the therapist, they would just hold the beam, just tell him, just keep the arms up. But this was a blinded study. This was a retrospective study. We deliberately did not show these images just to catch these effects. And it was one of the like a few first occasions where we caught something like this. So we can really expect that this will impact the field, and it should, and I think it will become kind of an additional part of the standard of care in radiotherapy. I got this just for fun. During COVID, we kind of were kicking around at home and locked down. We couldn't access clinics, anything. We were kind of thinking like, we have time to do something crazy. So how does the Cherenkov actually look like in color? Also, all the facilities were shut down. So at the end, we kind of figured out. So I was actually bought this piece of 1980s old camera, which had a beam splitter, RGB beam splitter. Back in the day, they were using Vidicons to create the image, and utilized that beam splitter to red, green, and blue, and equipped the outputs with the same cores that we kind of use in the cameras. Why it was necessary? Because again, there is not enough light in the room or to see the Cherenkov to be able to do anything else but something highly efficient that can split the image into red, green, blue. Developing this beam splitter, it was out of question because, again, it would be very difficult to do that with a light throughput, with the numerical apertures that would be required to actually get enough light to see something. So we got, I mean, it looks pink or kind of reddish. That was expected. But I mean, it was kind of fun project, but it lent us one of the sister Nature papers because just nobody's seen it before. And I think this was just like very fun project. And so over the years, the company just picked it up. There were some developments very early on. I mean, this is such an awful design. You can use it as a brick in your house or something. But it kind of evolved. We finally got FDA clearance with something that looks somewhat acceptable for clinics. We are now equipping, I think we got 6 centers installation. We're installing even further, 10 perhaps this year. I forgot the numbers, forgive me. And yeah, we're seeing things here and there in these centers, and people are actually realizing that it will have the impact that we kind of foreseen. And you know, the story would kind of end up here. The company picks it up, well, kind of this crazy development project at the kind of skunkworks project at the engineering school, and there you go, and you have to change the direction a little bit. So that was it. Well, not really. If it wouldn't be for flash radiotherapy. So this is, and I'm shifting a little bit the gears, but what is flash radiotherapy? This is a new crazy concept that came up in 2000, or was rediscovered in 2014. And it took a couple of years for the field actually to realize what we're dealing with. And suddenly there was a surge in everybody wanted to do flash in 2018. We jumped on that as well. The point is that now instead of the whole weeks or the course of radiotherapy, which is again to preserve certain features about this therapeutic window, we need to do that very slowly to prevent some damage. Now, what's been observed that if you squeeze this radiation dose and dose ray into to be delivered within sub-second, within a couple of milliseconds or something, you suddenly see a sparing effect. People would see the healthy tissue not being damaged as much as in a conventional mode, but the tumor control, the rate at which the tumor was killed, was the same, which would be absolutely game-changing, and it kind of goes actually against all the textbooks. So everybody was like, we were first cautious, and it was great. But thanks again to the radiation oncology and David and everybody, we were able to modify one of our linacs to deliver this and kick off preclinical flash therapy. It's got 2 major challenges. It's kind of obvious. By squeezing this therapy where people can actually just stop the beam, reposition patient, do all that, adjust even the therapy as halfway through the course. Now, the whole dose is, or perhaps in few fractions, you have these zaps of beams that are delivered in a eye blink, and all the safety mechanisms and the interlocks and the dosimetric detectors that steer the beam, they are not affected. They don't work anymore. They got saturated because of such a high dose rate. I don't want to go too much detail about how to achieve that, but it's really it's a very dangerous beam if one modifies it in a certain way to deliver these beams. So there's a huge exclamation mark or a huge caution about actually deploying this in the future clinically and actually realizing what do we need to control about these beams to be able to even do this in the future. So there's a lot of thinking what happens if we separate this in a couple of pieces if something goes wrong. It's a big question there, and again, the dosimeters that are built in don't work, and things that we rely on, typically you lose all the linearities and everything. And another part is it basically introduces this dose rate, the rate at which we deliver these beams, as a part of the dose optimization. So now the clinicians would have to start also looking at these are dose and dose rate histograms, basically demonstrating what the coverage of the tumor, with how much volume of it's got certain dose, and trying to minimize the organs at risk over here, right? And a similar concept would apply now for dose rate, where we would try to maximize the dose rate for the healthy tissue and minimize the dose rate for the tumor to induce this. So it goes against each other, kind of. But nevertheless, it's one part now of the field that needs to think ahead of time how to actually deliver this. And I just put this one. If you have not heard about this is about the safety and designing fail-safe devices, read about this device. It's a terrifying story, and this could happen if this goes wrong. So, but even then, I think we've gained quite a bit of confidence over the years with devices that are actually we are able to convert them for these high dose rates. These devices are mainly electron flash devices or electron linacs, and several proton centers are able to deliver these high intensity beams. The electrons, they work superficially because the interactions, they're working perhaps first centimeter or few for tumors, superficial tumors. And the protons, they shoot through the body, basically. You can use any energy, perhaps what you want, and achieve the high dose rates. The difference there is that the electron is delivered as one homogeneous kind of field, whereas the protons are delivered with actually like this, like with the pencil beam scanning, with the diameter actually of less than this laser. We're lucky that I actually right now have two machines, including Brůža testing this first one, or the second one, Mobitron. So we're aiming at, aiming at first clinical trial in the near future. And, but now again, we need to have some tools to first quantify these beams to gain trust in the safety mechanisms and everything, to be able to test it rigorously, and to also validate that what we're delivering is actually what's being planned, especially in the proton beams, because there's a lot of moving parts to deliver the proton beams. And also the definition of the dose rate is a little bit tricky with beam that's being scanned like this. You can think of peak dose rate, which is just like the maximum dose rate you got. You can get like average dose rate and so on. So there's also a lot of uncertainties about like what's the proper quantity here. So we thought our camera would be actually pretty good because it can image wide field of view. It can do it pretty quick. We can actually replace our CMOS sensor with a much faster 10 kilohertz readout sensor that streams the data directly, let's say, to the GPU. So you can use some processing in real time and develop methods to halt the beam. That's pretty rigorously done. We still need the intensifier because these beams, even though they're so bright, now we have to look even on a shorter time scales. So we keep that. The only thing, another thing that we need to replace is the dose reporter. Now, I discussed the Cherenkov emission, right, which is created in a tissue. But the problem with that light generated in a tissue is it gets diffused, it gets absorbed in the blood and other components. So it's not a very good dose reporter. So we have to replace it with something controllable. And that something is a scintillator, which is, again, you don't have to go through this, just two different types of scintillators, which are energy converters, high energy to low energy photon converters. It's a material that absorbs high energy photon or a particle, and through certain processes, it re-emits it as a shower of optical photons. And it does it with pretty good linearity, and you can get it in different shapes. It could be sheets, it could be like single crystals, you name it. Plastics, you can cast the plastic. So there is a lot of variety and a lot of freedom of actually designing what we want as a dose reporter. So we did this. We started, this is just an example. We started this in actually conventional radiotherapy for certain applications like total body irradiation, where the patient's skin is irradiated in once because of the skin lymphoma. And we wanted to quantify the doses across the body because there is a lot of unknown, kind of uncertainties. So we need to validate it on different spots. So we developed these discs that are scintillator discs that re-emit and could be used to, after proper calibration, you can use them as really dose detectors using just a single camera that's kind of far away. Similar thing we did with measuring those under control of their breast. That's another case. I don't want to go too much detail, but definitely ask me if you want. And very recently, we kicked this off. So we've designed the camera that we replaced the sensor, we deployed it. We partnered with several proton centers. I just highlight one of them, which was Cincinnati Children's Hospital, who were actually at the time running their first clinical trial. It was a feasibility clinical trial for FLASH, just to see if they're even able to deliver that with perhaps more palliative patients or with very low doses. So it was really just to study the feasibility. And we were the first ones to kind of validate that the beams that they were delivering, kind of independently validate, that the beams that they were delivering were what they prescribed. And there was another kind of observation or kind of thought about that. But we observed a lot of like variations, for example, in the dose rates at the surface. So now the field will have to realize that or optimize these beams, not to be just scanning like this, which causes this kind of weird pattern in the dose rate. That's because of just the definition. But now the softwares will have to like optimize this beam to kind of do some arbitrary kind of motion, depending on the size of the tumor, to maximize, let's say, the dose rate, for example. So there was a lot of very visual and very direct kind of feedbacks also for the team at Cincinnati. And so we designed these flat sheets, and it eventually evolved into, let's say, this, we call it like 2.5 dimensional. It's a deformable, semi-rigid plastic sheets that we would attach on a patient and perform this dosimetry in vivo to actually validate what has been planned, has been delivered, and independently on the machine parameters. And actually, with these devices, we will be able to provide way more information that the facility is providing to the researchers. They provide, let's say, one number that's like, yeah, we've covered 90% or 100% above certain threshold, but is that clinically valuable or not? Nobody knows. And we think that actually measuring as much as we can during these early clinical trials should be useful or will be useful to do comparisons, let's say, of the future outcomes of these therapies in between clinical centers, because this is agnostic to any type of like beam delivery type and scaling patterns and everything. Another good feature, I wanted to just mention a little bit of a technical detail here. This pattern, because it's so regular, actually we've combined the camera with the stereo vision. I'm looking at Roman, and Megan started and all that, where we can detect not only the light emitted from this tissue. You can see it's kind of deformed, but we can now transform this emission, as you can see here on this example, into a beam's eye view and really do the comparison as they would, as the clinicians would see that in the machine console, for example. And it also adds a pretty good feature of actually knowing exactly where this how this is shaped, and we're exactly in the room with sub-millimeter position, is this sheet. So we know where the patient is, how to, if the patient is in the right position, and actually recover with the help of this computer tomography scans, recover the volumetric doses and dose rate maps, and create these dose volume histograms and dose rate volume histograms. And I'm kind of relating back to the first slide, where these things are actually the ones that we need to validate and optimize for example. Or, so we think this in vivo dosimetry will kick off, and right now deploying it actually at Cincinnati, this enhanced version of that. We should go there anytime soon. And I think this was actually recognized, so we got quite a bit of funding for this. So even NIH is kind of knows about the challenges here, and they support us very nicely. And I hope with that probably in 2 weeks, the meeting will decide about our R01 to deploy these technologies in the clinics. So yeah, fingers crossed for that one. For the sake of time, I wanted to just jump into these last two more surgical navigation techniques, still using the similar kind of platform. So, but right now, looking at some more of a functional feature or functional, let's say, microenvironment signatures of the tissue, which is imaging hypoxia. And I'm not speaking about hypoxia that you may know from the pulse oximeters, which is just the concentration of oxygen in blood. This is really hypoxia in the tissue, or in fact, could be measured in mitochondria or outside of the cells. But it actually, we would like to deploy something or have a method of measuring the hypoxia, evaluating the hypoxia. Because in tumors, this is one of the key drivers of the outcome of the cancer and the cancer therapy. So if one has hypoxic tumor, it's more prone to become metastatic. It promotes angiogenesis, and it also suppresses the efficacy of the radiotherapy. So knowing, especially during, again, clinical trials or preclinically, about the state of the tissue that we are dealing with from within the cell would be really helpful, or at least add a little bit of more knowledge about whether we improve the treatment, let's say with the flash therapy or not. So now it's shifting from more like a functional imaging of the dose to functional imaging on a molecular level. And also definitely heard from Kim Samko's talk and Summer Gibbs' talk about fluorescence guidance and fluorescence assays. So we have, there are ways, it's actually a very good method to measure these intracellular or extracellular environment states using fluorescent or phosphorescent probes. Something that is basically a molecule that upon excitation, I kind of try to describe it in this Jablonski diagram, upon excitation, it can either go through fluorescence, but it can also stay in the excited state for a little while. It can transit to some little bit different triplet state, and either emit this excess energy as a phosphorescence, or depending on the probabilities, it can also dissipate thermally. The good feature of some of these molecules that can undergo this intersystem crossing and have certain molecular arrangement is that if there is in a vicinity, if there is oxygen, there could be a additional energy transfer from this state to the oxygen. So imagine that if you have this excited molecule in the triplet state and the oxygen comes by, this energy can get transformed or transferred to the oxygen. It's lost here, basically, and it just excites or changes the type of oxygen. It basically creates this singlet oxygen. It's actually one part of the reactive oxygen species on forward. If there is no oxygen, then this excited state would eventually, let's say, phosphorus, or there's additional paths that it can actually jump back, very low probability, but it can jump back and emit or de-excite through an emission of a so-called delayed fluorescence. So we can see that this is a nice mechanism actually to measure the concentration of oxygen in the tissue based on just like the intensity of this of these effects. I would say intensity, but you can also imagine that each one of these transitions is kind of can be expressed as a or with a rate constant. It's some kind of probability that that transition is going to happen or not. And remembering the rate constants and first order differential equations, one can actually end up with a kind of and we evaluate for the intensity over time. Can actually see these phosphorescence mechanisms actually being like or express themselves as a intensity decay if we look at the molecule that we excite with light and it's going to decay, right? So the exponential or the term in the exponent here will kind of be somewhat proportional to the concentration of the oxygen in tissue. And people use that and kind of evaluate, fit this with exponentials and get PO2 maps. And I quite remember Brian just barging in the lab one day and it's like shaking like, hey man, let's just forget all this. Let's just measure if there is this fluorescence or not, or delayed fluorescence or not. This takes a while to measure. You cannot do that in high speed or in image very quickly. So it's kind of not very useful method to do, let's say, surgical guidance. You need something that's really real time. And that's what was really this huge simplification of something that researchers try to always focus on and kind of get blinded to like some quantities here. But we can actually simplify it to like a most basic level. We just set the threshold in the time that sets a threshold of certain, let's say, concentration of the oxygen around. And that way we have actually a classifier. Is there hypoxia or not? Depending on where do we put these time windows that we measure. And we can actually, I didn't mention one thing. One of these probes is actually FDA cleared, or many of them, many of the drugs that are cleared actually induce this probe. So we can actually do it in patients pretty quickly because we don't have to go through any approvals, and it's impossible to actually get anything through nowadays. So we took our then Cherenkov camera, hooked it up to, instead of a beam of an X-ray, we put it in we synchronized it with the laser and reprogrammed the windows to detect in a prompt and delayed fluorescence, and voila, it worked awesome, actually. This is one of the early pictures that Arthur Petr saw, is now in faculty just spearheading this. This is a mouse tumor. This is what the doctors would normally see with the PP9 probe. This is prompt fluorescence, you don't see anything. But if we do certain, just look at the delayed fluorescence, you just see a nicely delineated tumor, take a ratio just to get rid of certain effects of absorption and everything, and get independent or tissue property independent measure of hypoxia in tissue. With absolutely crazy simplification of the original problem. So I just want to highlight this. It's many times the devices that we try to deploy that needs to be just the simplest possible, and it has to work 100% in the lab so to have any chance of succeeding actually in clinics, because it's, as we know, it's always like 10% of the whole effort to get it out to the field. And so we, I kind of designed or redesigned the Cherenkov camera. Now it's much more compact. Gluing the sensor to the intensifier is still crazy. We can put it to the resectoscopes or just handheld, and these are getting out also pretty soon. I forgot to take the final picture before I send it out. But there's one thing that keeps kind of bothering me. I may probably run out of time. Let's keep bothering me, which is the intensifiers. Like, this belongs to 20th century military, right? You can imagine, I mean, engineers, like, this is like a piece of art than a device like that we can scale up. it's basically, imagine you have a 2 centimeter, 200 micron thin disc that's right in the middle between these two glasses, which is filled with these holes, 7 micron thin holes, triple coated with some materials, crazy, sitting also 200 microns from the photocathode, and another piece of glass with a phosphor, 6 kilovolts between this plate and the phosphor, also coated, all sealed with ceramic spacers, indium seals. This is terrible. We can only get this because of the previous military kind of efforts to get this out in the field, because it's like 60s or something, or the first intensifiers were perhaps 40s. Not this, but yeah, right? So we looked at, it's analog bulky. It's got actually finite time. You can kill it actually in no time. So obviously we've looked at different sensors that would perhaps work. The problem is that the field is all oriented towards first consumer market, right? With sensor development. We always have to piggyback on device development or sensor development. First is consumer. Our phones, they take up maybe 40% of all the money spent on development of sensors. Second, I think I'll have a graph later. It's probably time of flight for automotive. I forgot, but we're kind of trailing with the medical field. So I always try to hack these devices that are repurpose them. It just never worked. The one for iPhones, nobody will give you data sheet for it. The time of flight, they're a little noisy. You cannot use them. The SPAD arrays, they're very interesting sensors. It's like much different than the CMOS sensors. They're single photon sensitive, but only single photon sensitive. So it's single bit detectors. Was there a photon or there was no photon? You need to read it out. There's another frame, 1 photon, no. So, and then you need to read this pretty quickly. And even with these readout rates of this 1 bit planes, that it's like 100 kilohertz. One would say 100 kilohertz camera, it's awesome. But for our pulsed applications, it's useless because what is that? 10 microseconds, right? 100 kilohertz. So we only will be able to get 1 or no photon per each pulse, and we gather 10 pulses in each frame. So, and to prevent even further like saturation, we need to detect at max like half of them or something like that. So useless. It's great, but for us it's useless. So I see Karthik there, yeah. So we had to partner with no one else but the best, inventor of the CMOS sensors in the world, sitting right there. And we just kicked it off, so hope for the best. I think it's going to be a great effort. Yeah, that's the graph. It's not that bad, but it's all more like portable devices and the cheap devices. It's really these to pick up. And defense, right? That's another field. So, yeah, maybe we can actually be part of this pie there. I got 5 minutes, so I got 3 slides. The last category is probably the most, not craziest, but perhaps challenging in the beginning. Efforts is to remove the remove the subjectivity from surgical guidance using these fluorophores. Because, again, you probably know in certain types of surgeries, for example, brain surgeries and other types, you can use, and there are FDA-cleared probes that will either get generated in the tumors or will, through certain molecular processes, get attached to the tumor, or will just be passively stuck in a tumor. And during the surgery, you open up the patient, you turn on your fluorescent light, and you can either directly with your eyes, actually, or through the surgical microscope, see the intensity outline or where the tumor is. It's used to improve basically the completeness of the resection, debulking. It can identify lesions normally you would not see, or it can identify nerves, for example, or features that you want to preserve. Summer Gibbs was talking about this. I think the problem still here, there's 2 problems, I think, or challenges again. One is the probe specificity. That's not my field of, that's for molecular biologists and the designers of the probes. But also one field which kind of bothers me is with the subjectivity. I mean, this is supposed to help the guidance, but and remove the guesswork of the surgeon. But now you get some blob that got diffuse edges. It's got absorption in due to the blood, and there is blood pooling. You don't see anything. I don't think if I have the example here. You see basically, I mean, compare this to the radiotherapy, which is precisely there were 4% accuracies all around. This is crazy. We don't even know what threshold to apply to these lesions. So one effort would be to kind of remove all these tissue absorption, scattering, all the effects in the simplest way possible. In simplest way in terms of the assembly of the device. So this would be probably the last slide. This is our last effort, perhaps the youngest effort, where we would utilize a very fast pulsed laser and a very fast, actually SPAD sensor, and utilize the fact that, or the time of flight kind of feature. We know that it works for cars, it works for machine vision. The problem is for these applications, the light travels it took 3 picoseconds to travel 1 millimeter. So we never will get like a millimeter resolution with these time of flight, or at least now the sensors have some finite jitter and so on. So they're too slow basically. But when the light enters the tissue, because of the multiple scattering and everything, it slows down actually. The light envelope slows down. And suddenly it's on hundreds of picoseconds per millimeter kind of range, plus or minus. So we are able to detect these, the response of just the tissue itself. And the idea would be now to detect not just the fluorescence, but another, like the simplest thing would be a reflectance, and some way reconstruct it and correct for these absorption and scattering and depth involved kind of effects. Like if you have this at depth, obviously the intensity will be lower. So is that useful or not? So we would like to correct this and present the surgeon with something that's really objective. The problem always was that this is untractable. This is a super hard problem. The tissue diffusion is analytically insoluble, really, except for certain niche cases. But I think it's a very interesting case for machine vision. So deploying this, Shirvang is trying to, right now with SPIE, talking about this. And this will be the last thing I have. So just to conclude, thank you. Vision, as Brian Polk summarized, it's a huge market, but it's up to us now to kind of present it in a way that's the simplest possible. And with machine learning now and the AI assisted thing, we actually need to know how to present it in a accurate way, right? We need to bring in confidence metrics that are easy to understand, and how to improve how to embed these vision applications to actually real life. And I would just wanted to thank everybody for this is an amazing team. I didn't mention the students. This is all work of the students. I see Roman, Megan, Kevin, and Natasha there, Xander and Shiru. Obviously, thanks so much to my mentors. First and foremost, Brian and David, and Rumja was a great colleague. Without Leslie, we wouldn't be able to do any of the clinical work. Arthur is taking up a lot of the work, and our external collaborators, surgeons. Thanks so much. Thanks for listening, and I'll take questions later. Thank you.